Hello everyone, I am Dr. Aarti. We'll discuss heart in 3 PPTs. In this PPT, we'll see about ischemic heart disease as well as heart failure. You all know the main function of the heart is to pump blood to the peripheral tissue. This can be maintained only if ejection fraction, that is EF, is maintained above 60%. Whenever that EF is very low, it cannot meet the demand of the peripheral tissue as the heart cannot pump blood. This results in heart failure. So heart failure is a condition in which the heart cannot pump the blood adequately to meet the metabolic demands of the peripheral tissue, or it can do so only at the elevated filling pressure. So the normal filling pressure will be around 2 to 6 mm of mercury. So heart failure, there will be a progressive deterioration of the myocardial contractile function, and there will be also decrease in the ejection fraction. Heart failure is classified into left-sided as well as right-sided heart failure. So coming to left-sided heart failure, here the causes are related to mainly cardiac related. So the most important common cause will be ischemic heart disease followed by hypertension, and in valvular disease it is aortic as well as mitral valvular diseases and other primary myocardial diseases. So in left-sided heart failure, there will be a congestion of the blood in the pulmonary circulation as well as stasis of the blood in the left-sided chambers. So as there is a stasis of blood in the left-sided chambers, there will be an inadequate perfusion of blood into the downstream tissue, which leads to organ dysfunction. This left-sided heart failure is further divided into systolic as well as diastolic failures. Coming to morphological changes associated with left-sided heart failure, the heart as a result of common centric mechanism will undergo both hypertrophy as well as dilatation. There will be also dilatation of the left atrium, which increase the risk of atrial fibrillation as it affects the conducting systems of the heart due to dilation. There is a dilation of the left side chambers of the heart, so there will be stasis of blood which increase the risk of thrombus formation. So microscopically, there will be myocyte hypertrophy as well as interstitial fibrosis. So in lungs, we have already seen there will be a congestion of the blood in the pulmonary circulation. There may be also pulmonary edema, and one of the characteristic findings seen in lungs in left-sided heart failure is the heart failure cells. This heart failure cell is nothing but a hemosiderin-laden macrophages. This is an important MCQ. They can ask heart failure cells is seen in which sided heart failure. Along with this pulmonary congestion edema, there may be also pulmonary pleural effusion. And radiologically you can see Kerley B lines. Kerley B lines indicates there is a presence of pulmonary edema. So this patient will come with cough, dyspnea, orthopnea as well as paroxysmal nocturnal dyspnea. So orthopnea is nothing but the patient will develop breathlessness during lying down position, and paroxysmal nocturnal dyspnea is the patient may develop sudden breathlessness during sleep. So in kidney, as there is a reduced perfusion due to stasis of the blood in the left-sided chambers of the heart, this activates the renin-angiotensin system. So this results in the expansion of the interstitial as well as intravascular fluid volume. So due to the reduced renal function, there will be impaired excretion of the nitrogenous product which causes pre-renal azotemia. So in brain, there will be a hyperperfusion. This may result in hypoxic encephalopathy which results in ischemic injury to the brain. So coming to right-sided heart failure, this right-sided heart failure may develop secondary to left-sided heart failure, or it can develop as a result of cor pulmonale. So cor pulmonale is nothing but any pulmonary disorders which results in right-sided heart failure. I have given a list of disorders which results in right-sided heart failure, pulmonary disorders which cause right-sided heart failure in the second PPT. Just go through it once. So here in right-sided heart failure, the pulmonary congestion is minimum. So pulmonary congestion will be prominent in the left-sided heart failure. However, in the right-sided heart failure, this pulmonary congestion is minimum. However, there will be a stasis of the blood in the systemic circulation. Okay, systemic and portal system congestion of the blood will be more pronounced in the right-sided heart failure. So coming to morphological changes associated with the right-sided heart failure, the heart as a result of as a compensatory mechanism, this heart will go for hypertrophy and dilatation of the right-sided chambers of the heart. So coming to the systemic circulation, due to the congestion of the blood, there will be both congestive hepatomegaly as well as congestive splenomegaly. So this congestive hepatomegaly grossly will have a nutmeg liver appearance. So this is a gross image of the nutmeg, and this is a gross image of the liver seen in right-sided heart failure. This is mainly due to congestion of the blood in the pericentral areas with a normal tan appearance of the periportal areas. So in chronic heart failure, right-sided heart failure, there may be also the liver may undergo fibrosis which results in cardiac cirrhosis. So they can ask a question, cardiac cirrhosis seen in which side of heart failure? This is seen in right-sided heart failure. So along with the other findings, there may be also ascites, pleural effusion, pericardial effusion as well as generalized edema. So in kidney, as there is a severe congestion, this may also leads to renal failure which leads to azotemia. So coming to diagnosis of the heart failure, the diagnosis depends upon the two peptide. One is atrial natriuretic peptide as well as B-type natriuretic peptide. This B-type natriuretic peptide was previously called as brain natriuretic peptide because it was first isolated from brain. The serum level of B-type natriuretic factor was used to assess the extent of chronic heart failure. This is released by the ventricular cardiomyocytes during wall stress. Nowadays, drugs has been manufactured to prevent the metabolism of this BNP, so it can be used to treat the heart failure patients. So along with this peptide, echocardiogram is also used in order to diagnose the patient with heart failure. So next, coming to ischemic heart disease, this ischemic heart disease usually occurs whenever the imbalance between the perfusion as well as the demand for the heart occurs. So it's a condition when the imbalance between the myocardial supply, that is perfusion, and the cardiac demand for oxygenated blood occurs. So ischemic heart disease usually occurs in a spectrum of disease like MI, angina pectoris, chronic ischemic heart disease with heart failure as well as sudden cardiac death. So the pathogenesis behind this ischemic heart disease is nothing but atherosclerosis. So whenever atherosclerosis undergoes chronic vascular occlusion or there is acute plaque changes or vasospasm or thrombosis, there is an imbalance between the supply as well as the demand of the heart which result in ischemic heart disease. So coming to angina pectoris, this angina pectoris is nothing but a sudden, that is paroxysmal and usually recurrent attack of retrosternal chest pain. The pain usually lasts less than 15 minutes. So the myocardial ischemic attack is insufficient to cause myocyte necrosis. As it is insufficient to cause necrosis, there is no release of enzymes. So this cannot be identified by the specific markers for MI. Okay. So this anginal pain is induced by the release of adenosine, bradykardine and other molecules that stimulate the sympathetic as well as vagal afferent nerves. So here anginal pain usually lasts less than 15 minutes and here there is no release of any enzyme from the damaged myocyte. Okay, so it cannot be this cannot be diagnosed by the routine blood test. Remember that. This angina pectoris can be of three types. One is stable, unstable as well as Prince metal. We'll see in the upcoming slides. So coming to stable angina, here the anginal pain is caused by the imbalance in the coronary perfusion relative to the demand of the heart. This can be induced by activities, emotional excitement as well as psychological stress. So here the pain can be relieved by rest or by administrating vasodilators like nitroglycerin as well as calcium channel blockers. Coming to Prince metal variant angina, here the anginal pain is caused by the coronary artery spasm and here the anginal attack is unrelated to the physical activities or heart rate and this can occur even at rest. They respond well to vasodilators. Coming to unstable angina, this is associated with plaque disruption or a distal embolization of the thrombus or a vasospasm. This is characteristic by a severe anginal pain which can occur even at a low level of physical activity or even occur at rest. Okay, so here this unstable angina may proceed to MI. So coming to myocardial infarction is nothing but a ischemic heart disease which may occur due to the imbalance between the demand as well as supply of the heart. You know the heart is supplied by the three main vessels. One is right coronary artery, left anterior descending artery and left circumflex artery. So here you should know in my MI area at risk. So area at risk is nothing but the anatomical area supplied by the occluded vessels. So the most commonly occluded vessels will be left anterior descending coronary artery followed by right coronary artery then followed by left circumflex coronary artery. So here these three main vessels are present in the epicardial zones. So the blood supply will occur from the epicardium to endocardium. So endocardium is the last area to receive the oxygenated blood. So irreversible injury most commonly occurs in the subendocardial zones because this is the last area to receive the blood by the epicardial vessels and there will be a high intramural pressure. So this is the irreversible injury is most commonly seen in the endocardium. So infarction can be of three types. One is subendocardial, transmural as well as multifocal infarctions. So coming to subendocardial infarction, here the ischemia involves 1/3 of the ventricle wall, that is involves the endocardium layer. So this is caused by incomplete occlusion of the vessels or systemic hypotension. Coming to transmural infarction, here the infarction involves the whole thickness of the ventricular wall. This is caused by the combination of acute plaque changes, atherosclerosis as well as superimposed thrombosis. Coming to multifocal infarction, here you can see small intramural, many multifocal infarction will be seen in the myocardium. This is mainly caused by occlusion of the small intramural vessels. Okay, so this can occur due to microembolisms, vasculitis as well as vascular spasm. So next the diagrammatic representation of this infarct. So here you can see due to the complete occlusion of this vessel, there will be a complete infarction involving all the three layers. So this is a transmural infarct. So here there is an incomplete occlusion. So only the subendocardium is involved in the infarct. This is a subendocardial infarct. In global hypertension, there will be a circumferential subendocardial infarct, and this is a multifocal infarct due to occlusion of the small intramural vessels or vasculitis. Okay. So coming to morphological changes associated with the ischemic heart disease, first gross changes will appear only after 4 hours. Before that, there will be changes in the biochemical changes can occur. So first there will be onset of ATP depletion which occurs within seconds, and loss of contraction will occur within 2 minutes, and ATP will be reduced to 50% of the normal within 10 minutes, and it will be reduced to 10% of the normal within 40 minutes. Irreversible cell injury occurs within 20 to 40 minutes, and microvascular injury will occur within 1 hour. So coming to the gross and microscopic features associated with the ischemic heart disease, read this table column once, but remember this highlighted points, these are very important. So remember, within 4 hours there will be no gross finding. The only microscopic finding will be waviness of the fibers. Within 1 day, that is within 24 hours, there will be a coagulative necrosis and there will be early neutrophilic infiltrates, and within 3 days, that is within 72 hours, there will be a interstitial infiltrate of the neutrophils. So grossly this infarct will have a yellow tan appearance. Okay. So within followed by neutrophils, there will be a infiltration by macrophages in which the phagocytic process will occur. So this changes can be seen within 7 days. So from 7 to 10 days, there will be appearance of granulation tissue. So granulation tissue is nothing but there will be a formation of new blood vessels along with fibroblast collagen deposition can occur. So at the end of 2 weeks, this granulation tissue will be well established along with increased collagen deposition. Okay. So at the end of 2 months, that is 2 to 8 weeks, there will be increased collagen deposition with decreased cellularity. So the blood vessels can also reduced. So after 2 months, there will be a complete scar formation. So remember this highlighted points. First, there will be a coagulative necrosis, followed by interstitial infiltrate by neutrophils, then phagocytosis by macrophages, then followed by granulation tissue, collagen deposition, as well as dense collagenous scar. So, whenever a gross tissue, that is a heart, is given to you and a history indicates that the patient has died by ischemic heart disease, there will be if the patient has died like within less than 4 hours, there will be no gross finding. So in order to diagnose if the patient has died by MI, we use a chemical called as triphenyl tetrazonium chloride. So MI less than 12 hours can be detected by triphenyl tetrazonium chloride. This is mainly because of an enzyme activity, that is lactate dehydrogenase activity. So the non-infarcted myocardial area will have a brick red color due to the preserved lactate dehydrogenase activity. However, the infarcted area will appear unstained. Okay, they have a pale zone due to the leakage in the lactate dehydrogenase activity. So here remember, less than 12 hours, we use a chemical called triphenyl tetrazonium chloride. This is mainly because of the lactate dehydrogenase activity in which the infarct area will have a pale zone as the enzyme has been leaked out. Okay. So this is the microscopic features. So waviness of the fibers is the first microscopic changes which is seen less than 4 hours. So neutrophilic infiltration is seen within 3 days, okay, within 72 hours. So granulation tissue, the peak granulation tissue will occur within it start to occur from the 7th to 10th day, and there will be a dense collagenous scar which occurs within 2 months. So coming to diagnosis of MI, the diagnosis of MI mainly depends upon the clinical symptoms. So along with that, there will be a following ECG changes like ST segment elevation, T wave inversion as well as Q wave. So coming to laboratory investigation, there will be, we use both specific as well as non-specific markers. So non-specific markers is related to the inflammatory process only. So there will be increased ESR, CRP as well as leukocytosis. So coming to specific markers, first markers will be LDH. So in LDH, normally LDH2 isoform will be more than one isoform. But in MI, LDH1 isoform will be more than LDH2. This is called as flipping of LDH ratio. This is an important MCQ. The other enzyme will be myoglobin. This is the earliest enzyme to rise. However, this is not specific because myoglobin can rise in any muscle injury condition. The next enzyme is troponin T as well as troponin I. In that, troponin T is more specific. This remains elevated for a longer period of time, around 7 to 10 days. So this is not specific for reinfarction. So next enzyme is creatine kinase. So creatine kinase occurs in 3 isoform. Okay, CKMM, which is seen in myocardium as well as skeletal muscle, CKMP, which is seen in myocardium and found less in skeletal muscle, CKBB is found in brain as well as lung. So in myocardium only CKBB is not found, and CK elevation is seen, MP elevation is seen in MI, and this is the enzyme of choice for diagnosing reinfarction because it returns to baseline within 72 hours. So whenever a person develops reinfarction during the admission or after 10 days, this will be the enzyme of choice. Okay, CKMP will be the enzyme of choice for diagnosing reinfarction. And go through this table column once. So CKMP will will rise within 2 to 4 hours following a MI, and it returns to baseline within 72 hours. Troponin T and I will return to baseline after 1 week, that is after 7 to 10 days. And LDH, it remains to baseline only after 2 weeks. So this is the enzyme of choice whenever you want to diagnose MI in a patient after 10 days. AST and SGOT is a non-specific enzyme, and this the initial rise will occur within less than 12 hours and return to baseline within 4 to 5 days. So coming to reperfusion injury, so whenever you treat a MI patient by thrombolysis or angioplasty, the patient will have a worsening of the symptoms. So this is mainly due to myocardial dysfunction on free radical injury or a complement activation. This results in myocyte hypercontraction. So we have seen in MI the infarct will be a yellow tannin color. However, the infarct here will be hemorrhagic. Okay, and microscopic changes seen in the reperfusion will be contraction band necrosis. So coming to complication of MI, the main complication will be contractile dysfunction, papillary muscle dysfunction as well as right ventricle infarction, myocardial rupture, arrhythmia. In arrhythmia, ventricular fibrillation will be greatest in the first hours. Thereafter, the risk of arrhythmia will decline. And next complication is pericarditis. This is an important MCQ. So the pericarditis associated with MI is Dressler's syndrome. This is mainly due to the formation of antibodies against the damaged myocardium. So this is of autoimmune origin. So along with the above complication, the patient may also develop thrombus formation, aneurysm, as well as there may be also progressive heart failures. So we'll discuss certain important questions. Okay, the most common causes of left-sided heart failure. So we have seen the most common causes of left-sided heart failure is related to heart. So in that, the most common cause is ischemic heart disease. So MI is one of the ischemic heart disease. So the answer is MI. Heart failure cells are seen in. So heart failure cells are seen in which type of heart failure is left-sided heart failure. These are seen in lungs. Okay, these are nothing but these are hemosiderin-laden macrophages. So the answer is lung. So next question, an elderly male presented with sudden substernal pain and died within 3 days. Died within 3 days. On autopsy, there was a large transmural anterior wall infarction. So this indicates the patient has died because of MI. So it is associated with, is nothing but they have asked the microscopic feature seen at the end of 3 days in a patient died of MI. So at the end of 72 hours, 3 days, there will be increase in the neutrophils infiltration will be increased. So that the answer is presence of neutrophils. So granulation tissue is seen at the end of 7 to 10 days. There is no granulomatous inflammation seen in MI. Presence of collagen and fibroblast will be seen at the end of 8 weeks. Okay. So the answer is presence of neutrophils. So remember, within 72 hours means presence of neutrophils. After 72 hours there will be a phagocytic process will occur due to presence of macrophages. So next question, a myocardial infarct shows a early granulation tissue. So they have asked the time period, okay. So within less than 1 hour there will be no microscopic feature. Within 24 hours, within 4 hours means there will be waviness of fibers can occur. So early granulation tissue, it occurs within 7 to 10 days. So the answer is within 1 week. So the cells seen after 72 hours in the infarct area in MI is, so within 72 hours will be neutrophils. After 72 hours there will be phagocytic process, so there will be a predominance of macrophages. So the answer is macrophages. Next question, in MI, the microscopic features of coagulative necrosis with neutrophilic infiltration. So coagulative necrosis with neutrophilic infiltration is seen within 1 to 3 days. So next question, the earliest microscopic changes in MI is waviness of the fibers. Next question, troponin T is a marker of, we have already discussed, is a marker of ischemic heart disease, that is MI. Next, the most common artery involved in the myocardial infarction is left anterior descending artery. So the first artery to be involved in the MI will be left anterior descending, followed by right circumflex, followed by left circumflex artery. Next is Dressler syndrome. So Dressler syndrome is nothing but a pericarditis which is seen as a complication following a MI. This is of autoimmune origin. Okay, so the antibodies are formed against the damaged myocardium. So next question, the heart muscle contain the isoenzyme. So creatine kinase, there are 3 isoenzymes. So in heart there are found 2 isoenzymes, that is MM as well as MB. So the answer is MM and as well as MB. The enzyme elevated in the first 2 hours of MI. So which is the enzyme to be elevated in the first 2 hours of enzyme is CPK-MP. And CPK-MP is also the enzyme for reinfarction because it returns to baseline within 42 to 72 hours. So next question, the post-MI day 10 enzyme, which enzyme is raised is, so day 10, so CPK creatine kinase will come to baseline within 48 to 72 hours. Troponin will come to baseline at the end of 1 week. So LDH remains elevated for more than 2 weeks. So the enzyme of choice at day 10 will be LDH. A 7-day-old MI, the most sensitive biochemical marker will be troponin T. Okay.